think this was already presented, that 10% of cancers in the kingdom out of all cancers is colorectal. But let's look at the global cancer statistics, which are produced every year. The colorectal cancer in males is the third one in developed countries and the second one in females. However, if you look at developing countries, it's much lower, it's less common. Saudi Arabia probably is worse than the developed and the developing countries. And if you look at colorectal cancer in terms of age groups, in all age groups, it's the commonest in males, so let's concentrate on males. And of course, in youngsters below the age of 30, it's the least commonest, but once you pass the 30 years of age, it moves to number one and continues to be number one all through. And even in females at that age of 75, it's number one. This has already been presented. The number of cases we see is around less than 1,000 a year. And I want to draw your attention to the lower part of the curve. It's only 10% of all cases. And this already had been presented, but what's so important is that you look at the median age for females at presentation is 54, for males it's 60. Compare this to the US, it's 71. So should we start screening at a younger age? And this has been stable over the past 10 years. So the median age at presentation, in spite of the fact that we have increased life expectancy, has remained at 55 for females, 60 for males. Now, the incidence of colorectal cancer is the highest in the three major cities, Riyadh, Eastern Province, which is Dammam, and Mecca. And this is understandable because the tertiary care centers are located in these major cities. However, if you plot this against the map, there is a trend for colorectal cancer to increase as we move north and as we move east. And if you follow this notion, then you expect colorectal cancer to be more common in the countries to the east of Saudi, like Qatar, Kuwait. And indeed, this is the case. If you look at Kuwait, Qatar, and Bahrain, they have higher incidence compared to Saudi. Now, if you look at the incidence over the past 15 years of colorectal cancer, you'll see that there is an increase at an annual rate of 10.3%. And we're reaching a plateau in around 2008, 2007. And the interesting thing, why are we having this increase? It's probably because of increased registration. We didn't have a registry before. Probably increased life expectancy, better diagnosis, and increased incidence of obesity in the country. Now let's look at the international trends. In the US, colorectal cancer incidence is dropping down, including the mortality from colorectal cancer. In the UK, it's also dropping down, but is increasing in Saudi. Now let's look at the US. 150,000 cases a year, 1/3 of them is rectum. Let's look at Saudi. Around 1,000 cases, and if you look at the age standardized rate, you'll find out Saudi is about 20% of the incidence in the US, and the other interesting finding that half of the cases are rectal. So we have worse in terms of site. Rectal cancer has worse prognosis compared to colon cancer. Now let's look at the stages. If you look at this curve, Saudi is the green line. You'll see that Saudi has more advanced cases compared to the US. Look at the arrows. This is the advanced cases. And if you, at time of presentation, half of the cases presenting in Saudi with advanced disease. Now let's look at the 5-year survival. This is based on 500 sample collected from the National Registry, and at the same time cases operated at King Faisal. Icebester in 2000 presented his rectal cancer cases, and his survival was 40% compared to the US, which is 60%. So we're lower. And the reason probably more advanced cases, more incurable cases, and more rectal cases. This probably puts a demand on more palliative care in the country. There is a need to have an institute and specialized palliative care all over the country. Now if you compare it to the US, stage by stage, you will see that even for early stages of colorectal cancer, the survival in Saudi is less than the US. And in early stages, There is no need for chemotherapy, there is no need for radiation. It rests only with surgery, surgical treatment. So the type of surgery presented in this case probably is inferior to the West. And you can look at this on this slide. Saudi is red here. You'll see the survival in local disease is 60%. It should be 90, but it's 60%. Now, if you further go into this quality of treatment issue, that the same 500 sample from the National Registry, the survival for females is 50% and for males is 40%. Compare this to the US, 60%. Now, females have better survival than males, but look at this. The survival in surgeries operated by general surgeons is 40%, while the survival for surgeries operated by colorectal surgeons is 57%, reaching that of the US. This is in Saudi. So our patients are not operated by specialized people, and as a result, they're getting inferior results. Now, whom do you want to screen then? Are you going to screen younger population at the age of 45? And this means that you'll have to screen 2,200,000, or stick to the international guidelines of 50 years, and you're going to screen 1,600,000. Next question. Are you screening for 1,000 cases a year? Because if you're doing this, it's not cost effective. But are you screening for polyps? And if you're thinking of polyps, the extrapolation from the data, probably we have an incidence of 2% of adenomatous polyps in our population. And in this case, if you're screening for 50 years and above, then you're looking for 31,000 individuals. If you're looking for 45 years and above, then you're looking at 44,000, 13% of the population. Okay, let's look at the data. Can we do it? I mean, do we have enough personnel? We have 300 gastroenterologists, according to the Saudi Commission for Health Specialties. We have 20 colorectal surgeons who perform colonoscopy, and we have 150 other specialties who perform colonoscopy according to data retrieved from the annual report of the Ministry of Health in the peripheral hospitals. Total, 470. Now, if you look at the NHS service in the UK and Japan, screening, probably each individual will take 1 session a week, 6 scopes per week. If you add the data, then probably all of them will do 100,000 scopes a year. The demand, based on the data I presented earlier, is for 300,000 scopes a year. So we cannot meet the demand even with this population of gastroenterologists and colorectal surgeons. Mind you, only 12% of the gastroenterologists are employed by the Ministry of Health. 58 gastroenterologists only out of the 300 are employed by the Ministry of Health, which provides 60% of healthcare in Saudi. And mind you, the 300,000 scopes that I alluded to will meet only 20% screening of the target population. So the solutions. Are we then going to include colonoscopy training as a compulsory thing in the boards of family medicine, in the boards of medicine, and the boards of surgery, which was already adopted in the US and Japan and UK? Is the Saudi Commission for Health Specialties going to approve the category of physician assistants like the US, Canada, and UK, who are allowed to perform flexible sigmoidoscopy? Well, let's look at the tests. This is the cost of the tests. Fecal alkaline blood, Colosure if you're using immunology. If you combine them, 160 riyal. If you're doing FlexSeg, 1,150. If you do colonoscopy, 4,500. Now, most of you will say this is more expensive than the private. Well, these values were done through a team from Waterprice who visited the Ministry of Health and calculated everything, including infrastructure, including the paperwork, including the mailing, including the results, including the technology, including the software, the hardware. And the cost is this, and it's pretty cheap. The average cost of a colonoscopy at King Faisal is around 12,000. That is cheap. Okay, let's look at age groups. If you're taking age group 45 to 49, this is the number of scopes you need on a lifetime, of course, and this is the number of flexible sigmoidoscopies, colonoscopies, fecal to occult. And if you go and crunch the data, this is what you get. Pretty expensive. Pretty expensive. For if you try to adopt a cost, you're talking about billions for a lifetime. But let's go per year. The cost for flexible sigmoidoscopy per year is about 36 million. For colonoscopy is 18 million. But if you're doing fecal occult plus ColoSure, which is an immunologic test, then it's 67 million. And it's pretty understandable because you're doing more. You're doing two samples and you're doing every year. So it's more costly to use fecal occult and blood than colonoscopy. Okay, now if you adopt the standards based on the American Task Force against the colorectal cancer, which delineated the strategy to do screening, and if you look at the third line, fecal blood plus ColoSure 900 plus flexible sigmoidoscopy, we're looking at a cost per year of 104 million. If you try to do colonoscopy only, that's 18 million. But mind you, colonoscopy is not an option. We do not have the staff to do it. Okay, if you're looking at a screening program, then probably based on the population of Saudi and the international guidelines, we need 60 sensors to provide the service. We need center for certification. Screening is more difficult than locating cancers. What people misunderstand that screening is easier. No, it's more difficult than cancer. Cancers are big tumors, you can easily see them. In screening, you're looking for smaller polyps that you should not miss. So it's very difficult. And therefore, there is a need for certification. Not every gastroenterologist should be doing screening. There should be a certification mechanism to identify those who should be allowed to do screening, like in Japan. Second, there is a cost of salaries for these individuals. There is a cost of testing for these individuals. And there is a cost per year. If we're targeting, for example, 20% of the population, then we're looking at a cost of 154 million. If we're targeting 50% of population, target population, the 2 million or the 1.5 million, then we're looking at 385 million per year cost. My conclusions, Mr. Chairman. Survival in Saudi is less than the US. 50% of our cases are advanced. They present at a younger age compared to Western countries. And the age and sex-adjusted rate in Saudi is only 20% of the US. And the annual cost is about 400 million per year. And it's not cost-effective a strategy if you're looking for 1,000 cases per year. And if you're going to do it for polyps, then we do not have the infrastructure for screening in terms of personnel, certification, governance, and categorization by the Commission. Thank you.